and I'm using dual screens here, so bear with me. Okay, so we tonight will talk about biofilms. What are they? What are they not? Where's the murky waters? How do we uncover them? But just to give you a little background about myself, I could go and I could tell you what I've done in my career, and I could tell you what I'm about to achieve in my career. But honestly, I'm a mom, I'm an injector, and everything that I have learned, I learned the hard way. So today, I don't stand here as a peer above, I stand here as a peer right next to you all. And I had to learn the hard way. And when I think about learning the hard way, that means a patient suffered. So for me, it's really important to share everything that I have learned along the way because everything that I give, I'm ultimately, it's the end goal is the patient. So I get asked all the time, like, why would you ever train your peers? Why would you train somebody that's a mile down the road? Because that person could end up treating my friend. That's why I train my peers. We're peers, we're colleagues, we're not competitors. The patient care is at the end game. So, all right, moving along here. Tonight we will talk about, well, hold on, I need to just make this little screen smaller so I can see my screen. Okay, so biofilms is certainly something that's coming up in the literature. And when I look at the literature, it seems that biofilms has been here for a long time. We're just starting now to research it. And one of the problems with aesthetic medicine that I feel is because it is a cash pay business, because it is an elective procedure, we don't have much level one evidence. So much of our protocols are just based on expert opinion, and that can get murky because right now, expert opinion is not coming from where maybe some of the older injectors that have invested, 7+ years. We look at our evidence coming from, case studies and, controlled trials. And I feel that the younger generation and the newer injectors is looking for expert opinion and considering it coming from social media. How do they validate social media? So there's a little bit of a disparity between knowledge and actual knowledge. So tonight, my goal is to help sort of demystify some of the Instagram versus Insta famous versus case studies out there and help to give people a practical approach to understanding biofilms. So I'm going to give people a definition of biofilms and then understand what is biofilms in aesthetic medicine. And then being able to explore our differential diagnoses. And how do we get to the diagnosis of biofilms is also important. And understanding early recognition signs and symptoms is certainly critical. I think as newer injectors, I remember personally myself thinking so many times a patient would come back and they would say, I feel this way, or I think this happened. And I would say, oh, well, it couldn't have been me. And, fast forward 5, 7 years, and I realize, oh, that was definitely me, or that was the drug, or that was the drug in this layer. And had I done this, it would have been better. Or that was the drug in my technique in the face of your immune system. So I've learned to say, it is me. So early recognition, I think, is really important if we actually can turn on our ears, humble ourselves, and care for the patient. And then also management. There's so much information out there on what to do. So looking at the differential diagnoses, we'll certainly explore that in a bit later on. Let me just figure out how I scroll. Here we go. So filler is the second leading requested service globally in aesthetic medicine. Of course, we know Botox is number one. The generic term for that is neurotoxin. So the concern here with biofilm in any adverse event is the temporary nature of hyaluronic acid filler really gives us a false sense of security, thinking, oh, it's temporary, it's just going to go away. However, once we plant that seed, it's not temporary. And that's what is increasing the risk of long-term complications. I believe that biofilms are woefully underreported here because there's the medical director, and then that medical director might have 10 to 15 people underneath them, so they report to the medical director and maybe perhaps misreporting to the pharmaceutical company, which then might base more studies and do some clinical research. So that's where the mismatch gets a little murky on evidence versus what are true results for adverse events and what are our true actual numbers of biofilm versus granuloma versus nodule, delayed early onset. And aesthetic injectors, their clinical diagnosis and treatment plan, literally, it's just based on loose expert opinion. There was times in the beginning when I started injecting, I did not know. So I would call a peer, but I didn't have a trial to go to. I didn't have a sound evidence. Like there was 40 level one clinical trials that suggested this, and there was 49 pieces of evidence that suggested this treatment algorithm is the best way with the most appropriate outcome. We lack that in aesthetics. So I think the more that we can turn to each other and then create case studies and just as much as we can possibly add to the evidence, I think will help newer injectors and then help us that are a little bit more seasoned as well. So biofilms are extremely difficult to culture and detect. That's why I think they're also underreported. And that results in incorrect diagnosis, mismanagement of the patient, perhaps an a satisfactory end outcome. It takes longer than it should. Vascular occlusion is certainly well studied because it causes immediate blindness. There's a direct and negative impact to the functionality of the patient, whereas a biofilm certainly could cause a direct impact to the functionality of the patient, but it's much more insidious, making it much less impactful in the news and in the research and to be talked about. So, adverse event management in aesthetic medicine, it really needs to up its game. So, I'm hoping if I can inspire even just one injector to turn into a researcher, I think it's going to make our industry better. It's going to make our patients happier. And when we have happy clients and they have amazing results, that is only going to turn to driving consumer demand, which will put more patients in our chair, which is ultimately what we want as well. So, with biofilms, there are 5 phases of biofilm development. But before we even get into the development of the biofilm, we need to understand what the heck is a biofilm. It's like we hear it, but do we know how to manage it? When I went to my first course, all I learned was to point and click. It was like paint by number. I have my paintbrush, I dip it in, and then I paint the number one. And then I rinse my paintbrush off, and then I dip it in the number two, and then all of a sudden I have a pretty picture. But what I was not taught was understanding differential diagnoses, how to IND, how to clinically assess the patient for adverse events. So instead of just hearing about biofilm, we really need to understand truly what is it. Biofilms are a little colony of microbes and they all clump together and then they develop this extracellular polymeric matrix, which is impenetrable to antibiotics, making it very difficult to treat. As we inject, we'll put our needle through the skin, and then, the causative agent gets down to those deeper dermal layers and it plants the seed. And it will take a long time for activation of that to occur, perhaps in autoimmunity or a virus or a dental or another hyaluronic acid dermal filler treatment can culminate and make that biofilm come to life in an active infection and an active abscess. Biofilms are very silent, slow growers that stay hidden in the dark until they have a direct insult, and then they become triggered and angry. And if we just think about the natural microbes that live on the skin, we have about 100,000 organisms that are all over our skin, and actually 100,000 organisms per square centimeter. on the skin. And it only takes 100 to actively cause a direct insult to our underlying tissues, either in an acute immediate infection or a larger infection, such as an abscess with some fluctuation, or a more insidious development of a low lying infection that is called a biofilm. So, proper aesthetic technique has to be done with every single procedure. Gone are the days of the little 1 by 1 square alcohol pad. I can't. So, as clean as possible. Once those gloves are on, there's no more touching of the glasses, there's no more touching of the hair. Don't fidget, don't fiddle. It's think of your clinical instructor, the worst clinical instructor you had as a nursing student or a PA student, and they made you redo that sterile dressing 19 times. Go back to those days. And that's how I want every injector to inject, because I think that's going to decrease our risk of biofilms. As much as we can do to properly cleanse the outer surface, there is about 20% of the skin's bacteria that lives beneath those deeper layers where antiseptics are impenetrable. So, yes, all of a sudden we've done our best possible cleansing that we can, and now we penetrated the skin. So, the best that we can do is make sure we have the right candidate and we have set up the stage for as clean as possible prior to entering that deeper layer that does have another layer of microbes living within it. There's a lot of information that's coming out there on the hypochlorous acid, and it has really demonstrated considerable and favorable outcomes in favor of the alcohol and the hibiclens. So I would encourage you all to perhaps consider switching to the hypochlorous acid as a better agent to help prep the skin. All right, so the formation of a biofilm, how does it happen? What's happening? We have learned that it is just a slow introduction of bacteria, and then it really creates this big casing. And as you can see, in this first picture, we have the attachment phase. So you have one little germ, it ends up in the wrong space in the wrong time. It's like wrong place, wrong time. And then gets in there. It has a nice, dark, hospitable environment to grow in. We just placed that bacteria down into that deep, dark space with a tube full of sugar. That's ultimately what hyaluronic acid is. We have to consider it like a little tube of bacteria, tube of sugar. So bacteria is likely going to grow on it. So if we put the filler in, whether it's biodegradable or the biostimulatory agent or hyaluronic acid, we really have introduced a foreign body. We attached it to a bacteria and then we put it in that warm, dark space. So, of course, it's going to grow, and then it grows and it starts to communicate. And then what will happen is it develops that extracellular polymatrix. And that is basically a coating of you can't touch me, I'm over here. It's like the best game of hide and seek ever. It's difficult to get it. So, when you culture it, it's going to come back negative. And like I said, it can be quite insidious and it's not going to crop up until we insult it. And then all of a sudden, it grows because, like any good bacteria, it wants to grow, it wants to develop its family. So it's growing inside. And then all of a sudden, it meets its maturation stage. And at maturation, all of a sudden it starts to disperse. It needs to develop greater colonies because that colony has outgrown its size. And so it starts to seed. And then we're seeding other areas that perhaps weren't treated with filler, making a dental service, that can proliferate the activation of a biofilm. Or if you do more filler, you don't intend to be clean, you've done your same sterile aseptic technique, and then all of a sudden we accidentally go right through that biofilm. We've cracked a hole in the colony and we're going to just disperse it throughout the body. So, when we're thinking of biofilm, of course, there's a million differential diagnoses, and I employ all of you to not just go and take aesthetic courses. What I really want you to do is certainly grow your skill with private hands on training. I think that is such a great way to actually grow your talent. However, it's equally important to go back and take an immunology course, take a dermatology course, and certainly take an infectious disease course. As we get into aesthetics, I think it is important for us to be reminded that at the end of the day, this is still medicine. We still need to have a fundamental understanding of our patients, their immune system, their emotions. It's a full wellness wheel that we're affecting. So I encourage all of you to not just solely focus on aesthetic medicine, focus on all of medicine so that you can treat the whole patient. You don't want to just paint by number. You want to be able to manage those quirky little things that can arise. So we need to consider just like a baseline infection, nothing too serious. It's very localized, easily managed with some antibiotics or an antibiotic topical cream. Of course, we discussed biofilm, so we'll, further develop that treatment plan. Then there's the non-inflammatory nodule, and then there's an inflammatory nodule. These two can be very confusing and get very murky when we're talking about biofilm. And then add on granuloma, and now everybody's really confused. Ultimately, the literature suggests that if you are dealing with a non-inflammatory nodule, if you are dealing with an inflammatory nodule and or a granuloma, you or abscess or infection, you really should be considering some biofilm activity. The least likely to have that biofilm activity is your non-inflammatory nodule because that will be in a very acute, comes on quickly, and tends to be because of poor placement. Perhaps we made a track, and when we were doing a linear retrograde thread, the filler filled up that track and got into a space that we necessarily didn't want it to. Or maybe we were too superficial. That tends to be a non inflammatory nodule. Inflammatory nodule is typically later onset. A granuloma is certainly of great consideration. However, we need to use the word granuloma only in the face of a pathological diagnosis. Unless you have incisioned and drained and biopsied that tissue, you may not use the term granuloma. You need to refer to these symptoms as a nodule, and then further studies can dial it back into the suspicion of a biofilm, because as I mentioned before, it's really difficult to diagnose a biofilm because it's so antimicrobial resistant. It's also resistant to the culture. A delayed hypersensitivity reaction is something that also used to be written off and clumped in, but now we need to think of a delayed hypersensitivity reaction could be more so. We just need to look at the immunity of our patients. If our patients get a little red and they get a little swollen and we're not suspicious of an actual infection, a hypersensitivity reaction, that's their immune system saying, excuse me, I'm not quite so sure. So there needs to be some confidence and some validation with a little bit of redness, a little bit of swelling. That is our patient's body saying, I've got you. I am on high alert all times. So that's actually a good thing, but we need to be mindful as it gets later on in the day, perhaps months to weeks out. Then we need to be not considering a delayed hypersensitivity reaction, but we need to begin to start thinking of that biofilm, that insidious, low lying, sneaky bacteria hiding within the depths of the tissue. And then also, of course, we forget herpes. It's so common, and we often write it off. But if we're having some sort of infectious process, we can have pain, itching, blistering, swelling, and a fever. Herpes will have all of the same treatments. And I want to take the herpes one step further. When patients, whether they have the diagnosis or not, I have learned to inject when I'm injecting the lip tissue, especially, which is a common space for granulomas. I am using a minimum of 4 needles because we know that the herpes virus lives on a nerve terminal. So it's typically in a quadrant. So I'll treat just the upper right with 1 needle. I discard that needle and then I'll treat the upper left with another needle, lower left, and the bottom right with all a different needle. Because my thought is, even if they're in that shedding phase of a herpes viral outbreak, which we'll never see, it's barely known to the microscopic eye, we could transmit it from any one of the quadrants. So I like to avoid that entirely and do my best to just make sure that I have a minimum of four needles per quadrant. So I had mentioned this earlier. Ultimately, that biofilm needs to be considered as the underlying causative agent for every one of those diagnoses that we talked about, the biofilm, not necessarily the herpes, but we need to consider it in our brain of like, maybe, I don't, just because they have a history of herpes, you don't want to write off herpes. That's why I bring that back in to this conversation because it can mimic other diagnoses. We have the delayed hypersensitivity reaction, the local infection, the abscess, the inflammatory, and the non-inflammatory. So we all love pictures. I think that helps so much with understanding what that it's great that I can talk about it. And I wish I had a little video to show you exactly what a biofilm looked like. However, what I can do is show you pictures of patients that I have actually seen. And I do want to ask, I love when you guys post screenshots of the learning that you're engaged in. I'm happy for you to share it. I just ask one exception with the patient photos. If you guys could not share, just because these are my patient photos and they have consented for me to use their photos, and I just want to reserve and protect that relationship. So if we could not share the patient photos, I would respect that. Thank you. So we have, this is so common, but this can happen in any area of the face. So this poor patient has poorly placed filler, and I think there was a mismatch. She happened to seek a provider that was not comfortable with the word no, or was just happy to keep filling. And the patient was very persistent in having more. So the key takeaway here is we've got to become comfortable with no. For any of you that have children, we say no all the time. It's time for us to look at our patients as our children, and we need to teach them lessons and boundaries, and that comes with the word no. This is a treatment. This is not ultimately a sale. We have to remember we have a prescriptive authority here before we have the sale. This patient had 4 syringes in 3 months. So this is not a Tyndall, this is not a granuloma, this is not a biofilm, this is just too much filler in one space. This poor patient has poorly placed filler as well. However, I think what happened here is the technique that they perhaps used was that fencing or tenting technique, and they perhaps crossed the wet dry border and got into the submucosal space, creating those really difficult bulges in order to reverse. So this is not filler that's going to go away on its own. We do have to act quickly. This can look like a granuloma or a nodule. However, it really just ultimately is poorly placed filler. So we do need to get some hyaluronidase in there and start dissolving that filler in the submucosal space. It can take up to 4 rounds of hyaluronidase to get rid of this, to restore that nice gummy line. The difference here is the firmness, the softness, and the onset. Typically, this will happen within 4 to 6 weeks, and those little bulges that you see will be quite soft and malleable, whereas a granuloma is going to be very articulated and quite firm and have more of a white hue than this particular patient does. Now, this patient is a nodule formation, delayed onset. However, if she had pathological testing, she most likely would have come up with a granuloma, and you're still going to treat it like you would a nodule. So she has filler encapsulated and high response to the tissue's not handling it well. This patient, unfortunately, I want to pet down my eyebrows when I talk about this poor patient. The injector was saving the syringe. She had one syringe repeatedly used over 6 weeks at 3 different intervals. This patient came to me 8 months after her original injection. This was 100% injector error. However, I'm never going to toss an injector under the bus. I'm still going to do my due diligence and think, does this patient have an underlying autoimmunity? Perhaps the injector didn't have the best of techniques, but let's look at the patient first before we throw people under the bus. And when I say throw people under the bus, I mean you silently do it in your head. You never do that to a patient. We always want to make sure that we are respecting our profession and finding ways to just not rip each other apart, but to help the patient ultimately. So this patient
Connie had an
was
interesting
not treated with any
comment.
antibiotics.
I'm sorry, I
Oh,
was gonna say,
yes,
Connie had a real interesting
go
comment.
ahead.
So she said, the patient with granuloma lips has a lot of channels in her tongue. Take a look at patient's tongue prior to injecting. This can look at the patient's health.
Yes, I like that. And that was where I was alluding back to, as much as we knew that this was an injector saving the syringe, we need to go back to primary care medicine and not just write things off. All right, and then malar edema. This can easily happen, and I see this happen most often with poor patient selection. And then perhaps there's some lymphatic stalling. The neurotoxins can help if they're done around in the orbicularis oculi area. It can help increase orbicular lymphatic stalling, which can make the malar edema even more prominent. Poor product placement, poor product choice. Maybe they picked a hydrophilic product when they should have picked a hydrophobic product. So there's a lot of variability with this. This is a patient that I absolutely would dissolve, but this is not a patient that I'm suspecting an underlying infection. And then, of course, we have vascular occlusion. We need to understand knowledge of anatomy, differentiation between tissue hunger and a bruise. I think that's really important and can help us differentiate from, after you have your first vascular occlusion, you think every bruise is a vascular occlusion. So going back to the basics and understanding platelet aggregation, what does a bruise look like? Can you get capillary refill in a bruise or can you not get capillary refill? Understanding those just fundamental basics will help you gain confidence. However, with this patient did have a vascular occlusion, but if you look at her nares, she has a little bit of lesions. Those bubbling lesions can be tissue hunger, so the skin's trying to open up so that it can get air in, or it can be a herpes virus coming, or it can be an infection. So a lot of these things they and they cross over, and we need to understand our differentials in order to make the proper diagnosis when we're thinking about truly a biofilm. So one
Tara,
thing that
one
yep.
more quick question. Um, First of all, if you will give an explanation of tissue hunger, just for people who might be
Oh,
watching
yes.
in the future. And then secondly, Abby wants to know if any research has been done to look at the rheology of different fillers and the increased risk of biofilms. For example, Vicross versus Nash technology. Have you seen certain fillers act more like implants instead of others, thus increasing the risk of biofilms?
I'm so excited for this question. My heart is like palpitating all over the place. Okay, so first I will go back to tissue hunger. So, tissue hunger is basically the vessels are not able to push the blood flow through, which is able to oxygenate the tissues underneath. So, the tissue gets hungry and it starts pustulating, and those pustules they pop and they break because they're trying to get oxygen down to the vessel, which is occluded by filler or some sort of obstruction. And then back to the studies of rheology versus product. Um, the studies so far to this date, I think this is a topic that is really going to come out on to the evidence scene. Currently, what I have seen in the literature is your biostimulatory agents are at you're at greater risk for a biofilm with the biostimulatory agents than you are with your hyaluronic acid. That is what is the evidence to date. And then to further that, when you layer a biostimulatory agent first, and then you put a hyaluronic acid on top of it, you have also increased your risk for biofilm. So, great question. The one thing that I also have learned is with vascular occlusion, this is another one of my soapboxes. If you're going to have a vascular occlusion protocol in your office, it means nothing if you do not have the supplies on hand because this is an emergent situation. We need to think of these patients like a stroke victim or a heart attack. Time is tissue. If you don't have it, you're dead in the water. Blindness is going to happen in 90 minutes. So again, we have to have the products on hand. I did a survey of over 200 injectors, and 98% of the 200 stated that they were 100% confident in managing a vascular occlusion. Of that 98%, 44% stated that they had Hylenex on hand to manage a vascular occlusion. 2% of the 44% actually had enough Hylenex on hand to manage a complication. I don't think people are intending to be rogue and Wild West. I think the information is not available to the masses of us, making us at risk for these adverse events and unable to manage them. So that is my goal, that is my passion, and why I want to connect with everyone. This was also a vascular occlusion. This was early stages, and this is a Groupon that she got. She had come to me and didn't want to pay the $700. She went to New York. She paid $225, and she ended up paying a New York surgeon $1,200 a day for 8 days in order to reverse her vascular occlusion. So technique is certainly important. And when she FaceTimed me after I told her what my price was, then she went to New York, she got her filler, and she FaceTimed me and I said, show me what they're using. They were using an imported product from France that said not injectable for topical use only. So again, they had supplies, but they were the wrong supplies. This patient ended up fine, but just these are some of the things that as we're thinking biofilm, we need to understand what our differentials truly look like in order to get to the crux of what we're talking about with a biofilm. And of course, this is just a bruise. But the thing that I want to point out is you could easily think, is this a bruise or is this a vascular occlusion? Because if you look at the top left photo, there does look like there is some white, maybe slower cap refill because the color looks different. But what I deduced from these pictures is they cleaned her makeup off. They didn't truly do a full proper cleanse. I'm into the practice now where my patients get a double cleansed, then they get alcohol, then they get the Purison when I'm in there. And if I turn my back to them, I clean them again before I go ahead and inject. So my suspicion is this patient is truly a bruise. And when you see that white pattern behind the bruise, I think that's just where they cleaned off their makeup. I do not think that this is an actual vascular occlusion. So then, as much as this looks like a vascular occlusion, this is a vascular occlusion, but it's also body dysmorphia. The top photo, this patient had 2 syringes of lip filler in her lips, and she came back and wanted more. And I said, nope, you are perfect. Your lips fit your face, and your tissue is as expanded as I feel comfortable with. So she left my office and she went and she got more. And then the after photo was her results. So body dysmorphia can drive our patients from practice to practice to practice to practice to get their aesthetic that they're thinking. However, we need to think of when we put the filler in, we're always asking the question, have you had surgery? Because we know what happens with surgery. The vessels and the tissues become rigid and fixed in space. So when we go ahead and put our needle or our cannula through, the vessels can't bob and weave out of the way as much as they could in a naive face. So we need to start looking at a previously filled face like a surgical candidate. We have to be extra mindful of some of these adverse events. So I think with this particular patient, perhaps she was so full that when the injector went to go fill her, the vessels weren't able to move out of the way. So she ended up with a significant vascular occlusion. And again, I think she was $10,000 into it by the time she had everything resolved. And what she was one of those moments where you sit back and you're like, what I do is not just aesthetics, it's so psychological. This patient ended up in she did commit herself to a mental institution to help work on herself. And it was for a solid 6 months. So I think we might just be thinking aesthetics, but we also need to keep in mind the mental aspect of our patients and where they truly are emotionally. And now we need to think nodule versus granuloma. How do we differentiate between a nodule and a granuloma? We can certainly ask ourselves some questions. What is the time of onset? If it's an acute onset, we're going to likely think injector technique, it's superficial product placement. Do they have a fever? Is there pain? Are there discrete edges, or is it kind of smushy like you would anticipate your filler to be? Is it fluctuant? Then we're thinking abscess. But we need to ensure that we cannot use the term granuloma in our documentation unless we have that pathological from an incision and drain and a pathology of the tissue. So it's a node until proven otherwise. So an abscess, going to be early onset, likely technique related to the injector. However, we need to make sure, does the patient go home after a CO2 laser and they go lay in their bed and their dogs and their cats and Fido's all snuggled up on them, or are they smokers? So even though it's important for us to realize our impact, it's equally important for us to realize, what are they going home to? What are they doing that they think is so normal? A patient that sleeps with their animal thinks that it's perfectly fine and their dog's the cleanest or their cat's the cleanest, their bed's the cleanest. But the actuality of the risk for infection with somebody that sleeps with their animal shoots through the roof. So we need to make sure that we do our best, but we also teach the patient what they should and shouldn't do. We can do a CBC, we can do a CRP, we can do an ESR, prolactin, and a culture. So we're looking for infective and inflammatory measures with all of these labs. Delayed hypersensitivity reaction. If we're truly thinking a delayed hypersensitivity reaction, we want to start to look at the IgG and the IgE of the patient. We can do the biopsies, and there's some literature that suggests perhaps even doing a tuberculin test as well. If it's a non-inflammatory nodule, it can be early or delayed, but likely this is going to be very easily managed, and we can just treat it acutely and it will likely go away without further long-term intervention. And inflammatory nodules, typically delayed, that's when we want to start thinking biofilm, and often it is injector related. And we certainly want to culture this if we can. And then if we are suspicious of for some more systemic inflammatory issues, we certainly could do those other labs, CBC, CRP, ESR, prolactin. Biofilm, of course, it's going to be delayed. It does tend to be technique related, and the labs are there. herpes, if the patient has never had it, this is difficult conversation that you're going to have with your patients if you didn't have it ahead of time, because they may have been exposed but never expressed the virus. And then all of a sudden we infect all this trauma to their lip, and the herpes is unveiled in the face of the trauma. We didn't cause it, it lived there to begin with. So it can be technique related. If you happen to have a patient that has a cold sore on their left upper, and then they pop up with a right upper and you didn't change out your needle, that's where it could be injector related. But truly, this is just a matter of they have it, they're sensitive to trauma, and we're going to inject them. A granuloma is generally late onset, technique related, yes, but these can be clues into your patient's underlying health conditions. And it's so important to be able to not just be an amazing aesthetic provider, but really develop and foster your fundamental medical skills. So, the treatment of an acute infection slash biofilm, there's a lot of different information out there. Where do you go? What do you do? I think it's great just to have a quick algorithm that you can pull up, because when these patients show up in our chair, we get so stressed out. We went to school to care, and then all of a sudden, we're the reason that they have an injury or they have an infection. It can be very unnerving to us. I think the best way for us to take control is when we have the tools in our hands and we have these little algorithms. I think all nurses and PAs and medical providers, we love our algorithms because it's a roadmap to clarity. So my preferred, when I'm thinking of an acute infection versus biofilm, I do prefer the clindamycin 300 milligrams POTID times 10 days plus ciprofloxacin, and that's 500 milligrams BID times 14 days. In prednisone, you can or you can't do. If I'm really thinking that is an acute effect infection, I'm going to hold off on the prednisone. If I'm thinking it's a long-term biofilm, I'm going to start with the antibiotics. I'm going to reserve my prednisone for my last ditch effort to take any bits of last minute swelling away. And if it's still unresistant, like it's just not going away, and it's still sort of hanging around, and you have those lumps and bumps like we saw with the patient that had the injector that did one syringe 3 times over 6 weeks, truly my suspicion is granuloma before a biofilm. You can use this intralesional step with the triamcinolone plus a whiff of Lido just to try and help encourage the pain relief. And then you can also cut it down with the bacteriostatic saline. We want to use caution in the triamcinolone, and we don't want to blast the skin. We are in a pattern of hyaluronidase. People just say, flood the area, flood the area, flood the area. But with triamcinolone, we need to be mindful of our volume that we put in, because we can truly cause tissue atrophy with these steroids. So if we need to do intralesional injections, be very precise and be very low on your dose. Bring them back time after time. If you're not getting improvement there, you can certainly add in the 5-FU if you have access to that. Just add it into your mixture. If I was suspecting a biofilm, I'm going to hit them with antibiotics first. Prednisone is in my back pocket for the late stages. As I get rid of the biofilm, then I'm going to consider a little hyaluronidase. If the hyaluronidase fails, that's when I'm going to pull out my steroids and go for it as those individual nodules pop up. If I'm getting somewhere, but I need to take it to the next level, that's when I'll bring in that 5-FU. So the purpose of these is because the intralesional steroids are going to decrease that extracellular matrix so that we can actually get at the globs. So that's the purpose of adding on that 5-FUs most specifically, is to get rid of the film that's not letting us get to the gobs. So we do need to be mindful and thoughtful I think it's fair to start with the antibiotics if you're thinking there's some sort of inflammatory and infection, because we don't want to go putting our needle in and seeding all of the infection around. But if there's no swelling, there's no fever, there's no redness around the area, and you truly think this is just a node, skip the antibiotic, try the hyaluronidase, and if that doesn't work, then go to the intralesional steroids. But just be mindful of the patient's habits too, and making sure that maybe we do need to use a little preventative antibiotics if they have a history of MRSA per se. So our first line of defense is our education and doing webinars like this. Before we inject, we also need to have informed consent. I think this is the one thing that we skip over so much. And it's because we want to rush. We don't want to scare our patients. We just want them to be comfortable and take the treatment. It is fair to have the conversation with your patient. The little signature that they get on the iPad is just not enough these days. And the reason why we want to take a minute and really have an explanatory informed consent is because we're going to give them the tools and the directions on what to look for. And if this happens, we want them to come back. We don't want them to Google. We don't want them to go to urgent care. We don't want them to go to their primary care. We want them to come back to us where we have the tools, we have the peers to look to help us get through these situations. When I have a filler patient, I always say, I want to share with you the risks and benefits. And the reason being is I don't want to scare you away from the treatment. I just want to give you the tools to be aware if, for instance, the rare occasion happened. I want you to have the tools so you know what to look out for and you're going to call me. Lumps, bumps, bruises, swelling, all normal, and I expect it to go away in about 2 weeks. Sometimes patients can have it up to 4 weeks. After I'm done your filler treatment, it's like your face stubbed its toe. That's the level of pain that I anticipate for you. Anything above that, I want you to email me. I want you to send me pictures. This is a relationship. This isn't a treatment. If for some reason 3 months down the road, you develop a little bit of fever, you develop a little bit of redness in the area, immediately call me. These are things that I can manage. And there's a host of complications that can happen. They don't always happen acutely. The last thing is you could have filler get lodged into a bit of a vessel. It creates an intense pain. You'll know it right away. The skin will become white. You email me, you let me know. You and I both show back up at clinic within the next day. I immediately dissolve it with my fridge full of enzyme. So yes, there's things that can happen. I share with you so that you know the signs and symptoms so that you can be a proactive team member for us to work with. However you want to spin it, whatever your personality is, just have the conversation. The Somebody had asked about hyaluronic acid versus, the varying types and the rheology and the Vicross technology. The other thing that I read in the literature is its injector technique. I'm seeing a lot on Instagram. Injectors are injecting with their cannula and they're actually touching their glove or their needle onto the cannula, or they're taking a gauze and they're taking their needle and they're like getting off the drip. That's increasing the risk for biofilm. Your gauze isn't sterile. You don't touch the needle or the cannula to anything except the entry point and get it in. Certainly put your bonnets on your patients, clean their whole face. We have a lot that we can do before we get to the patient to help set them up for success. And then the newest consideration, I did allude to this earlier, is layering over products, but more importantly, laying over another injector's work. And this is increasingly becoming frowned upon, not because I need to have all the patients or you need to have all the patients, but we don't know where they last went. Patients don't always know what they had. Patients, we don't, not all providers are created equally. So the kids at high school, you remember back in high school, it was always the last man standing. Whoever threw the last punch is the one going down for the crime. However, you as an injector, you may have been the last one to inject, but it likely was subsequent injectors prior to that inadvertently planted the biofilm seed, but you're the one on the hook for it. So I think we're going to start to have conversations with ourselves and with our patients about developing and nurturing the relationship beyond the treatment, because I think it's for their safety and I think it's going to help us avoid some litigation. Education is always paramount. Complication management is by far the largest unmet need within aesthetic medicine. Right along with, of course, my other soapbox is the standardization of education and regulations within this niche field. So the burden does fall on individual injectors, and we need to continually educate ourselves on aesthetics, on infection, on immunology. We need to be have a host of information available for us to have at quick recall. And most importantly, don't live on independent island. We are providers of health. We're team members. So reach out. I'm always a phone call away. I will always pick up the phone and help somebody get through an adverse event because no one should go that alone.
Tara, you are so amazing. As you're getting ready to kind of wrap up here a little bit, um,
Yes.
Dawn said that she thinks your algorithms are great, and she said she has your textbook series. Are the algorithms in your textbooks?
I believe in my dermal filler, we have a host of algorithms, but if she wants, have her send me an email and I can email her all of my updated algorithms because after I did my vascular occlusion policy, of course, it made me go back to the table and I was like, oh, well, I need to update this and I learned this, so I need to update this table. So there's very basic tables in her text, but if she wants, I can give her my updated versions, which really expanded upon the most current knowledge.
And I'm going to tell you right now, I'm probably going to get 15 pop-ups that go, may I have those too? May I have those too? So maybe if you would be so kind, maybe we could have you just send it to me and then people, so not to fill your inbox, fill mine instead. And I'm happy to share those with people, only people who request after watching the video.
Okay. Yeah, absolutely.
Um, and Dawn made this comment a little bit earlier. She said, Tara, great presentation. I'll be driving, so can't respond probably, but wanted to mention that I read a recent publication, a small study, that found there's better overall antimicrobial protection by using another agent, Hibiclen's chloroprep, along with the hydrochloric acid. Rather than just hydrochlorous alone. In my practice, we prep with hydrochlorous spray and then still use chloroprepping during treatment and then spray the treatment area at completion of treatment. She'll look for the article and be able to share it.
I
And
love that.
I'm laughing as I go down here because they're like, would you mind sharing the algorithms with us as well? Mary Beth, can you send to us? Melanie, yes, please. And Connie, I purchased your books at iSpan as well. Thanks for being so willing to share it. I also loved it. So like I said, it always, you guys are also kind. And Hermine did a great talk on GFEs, and so we've shared those with people who have asked after watching the presentation. You know, these are things that I want to make sure that we have ancillary learning tools to really support the learning for people who are Titan members, but I'm also very careful to respect your property and what you've done in terms of research. Um, Go ahead and talk to them about your adverse event management course, and then I want to give you a little bit of time to chat just real quickly about your dissertation on hyaluronidase protocol and what you're looking at publishing with that.
Sure. So, Connie and Don with the books, we have the filler courses but it's hard to just break it all down. So that's why I thought, I was trying to teach the adverse event management in the basic dermal filler course, but I feel like it's its own entity. It really is its own beast. We have to learn to, learn the technique. Then we have to learn how to be artists. And then we really need to be able to dig down and be able to manage those complications post-op if we happen to have them. And when I was doing the algorithms, I just thought, okay, so it's great. I'm charting down boink, boink, boink. Okay, so my thought process is going, but does it truly tell me I need a roadmap to success? I need to know Viagra, 50 milligrams, breathe into a brown paper bag for set amount of minutes, put pressure on eyeball for 1 minute, then release. I just needed quantifiable, tangible directions in order to, I needed a proper recipe in order to get the patient to safety. So that's why I went back to my algorithms instead of, they might be inflamed. Consider hyaluronidase protocol. If that doesn't work, consider intralesional protocol. And I would go to these conferences and they'd be like, oh yeah, just a whiff of triamcinolone and a whiff of 5-FU and just a dash of hyaluronidase. And I'm like, well, what did I just make? So I needed clear, specific directions. And that was the one thing that I was really hungry for when I was a newer injector, because these were all terms and languages that I was in the ER. I didn't dissolve things with Kenalog because I didn't grow up in derm. I grew up in the ER. I never grew up with hyaluronidase. So they were foreign topics for me. So when I'd go to these conferences, great conferences, but they were just talking so far over my head. That's why I was like, we need not a dash of salt. We need a fifth of a teaspoon of salt. So the recipes have just been dialed in as the farther I get into this industry, the more I'm able to dial it in with confidence. And that was something that I lacked in the beginning. So that's where the adverse event management course is going to be its own separate beast. And this also came off of the dissertation for my doctorate degree, which happened because I thought if I'm going to educate, I wanted to elevate myself to make sure that I was bringing the best approach to them. So it was more of, I felt obligated to go back to school to ensure that I was teaching appropriately and adequately, and I was teaching the right way and giving everybody what they actually need to cultivate the next generation of aesthetic providers. And it's all about vascular occlusion. And we do have a ton of information out there, but again, it's still based on expert opinion. So I created a protocol and I was able to implement it into a practice successfully with successful outcomes. So I'm hoping it's the first published protocol that is in US in units, not international units, and United States providers can actually use it because it's drugs that we can actually get our hands on.
You guys have heard my admiration for Tara and the research she's done. So here are a couple other quick questions. Judy once said she has your neurotoxin book and wants to know where to purchase the other books. I'm assuming on your website.
So I believe the bundle is there, but if she emails info@DCCM Academy, she can get the trio of neurotoxin, dermal filler, and facial assessment. And then if she wants to, she can get the trio, and then the adverse event management one will be done by March. And she can always add that on as a supplement, or she could wait and get all four.
Okay. And then Connie says she agrees that it's a ever-changing algorithm. Should change our underwear, be part of it. But I have to admit too, I was giggling as I was reading that out loud, Connie. So thank you for making me giggle. Abby wants to know, do you ever practice vascular occlusion protocol in your practice? Working the emergency department, we would run practice codes all the time to help remain calm and confident in stressful situations. So do you ever practice running VO protocols? That's an interesting question, Abby.
I actually do. There's another nurse that I learned from, and she used to call it Code Blanche. So we call it Code Blanche as well because I learned from someone else. And I just say Code Blanche. And I think because of the ER, I just go out to the desk and I say Code Blanche. And there's no yelling, there's no chutzpah, there's no, oh my God, there's no frantic notion. There's just, go get me what I need. I just need you in the room to support me. And we just go through everything and they document. I tend to be the one that's doing everything. And then they are there to simply document and perhaps hand me something. But it just allows that second person in the room allows me to be just very emotionally present with the patient. Because if we think about it, we have each other, we do have resources. There is a lot of information out there. So even in the worst of cases, we can muddle our way through a vascular occlusion. But what when the relationship is broken is when you cannot now manage the vascular occlusion. So a lot of these adverse events has to be about fostering that patient relationship to ensure that you have not fractured the relationship. They're going to come back, they're going to trust you, they understand the process, they understand at what point are they going to blister, at what point is the pain going to stop, at what point are they going to scab. That's going to instill confidence in them, and that starts right there in the practice when they have a crisis. But we're not yelling. We come in, okay, this is great. I'm noticing this. I'm going to get you through it. She's going to get this. Nobody yells. Nobody gets their knickers in a knot. I'm very calm. And when we have these codes, I actually ask everybody that's on my team, they have to speak in a whisper because it naturally sets up the notion that people are just quiet and they have to listen for my whisper of a voice in order to tell them the next task. So there's not all this hustle and bustle of like, "Oh, I'm doing this. Oh, I'm writing this. I'm writing this." It's very, very soft and calm. And that also helps to keep the patient calm.
Awesome. And as Tracy said, if you're calm, your patient will be as well. And you guys so set the stage for great education, for patient reaction, and for handling whatever. Um, and that goes into good patient selection, I'm sure as well, which I think we're going to have another talk later on this year about, because that's something that I have noticed might need to be discussed. Um, Abby says,
Uh-huh.
thank you so
Yeah.
much. This was very helpful. She can't wait to meet you in person. I'll put in a quick plug. Tara will be one of 18 amazing legacy injectors that will be presenting at the Learners and Legacies meeting that Titan will be hosting this summer in Chicago, June 23rd through 25th. We're going to hopefully have the website for registration up on Monday. It will be $700, and that will include all of your meals. We'll start at noon on Friday, go till noon on Sunday, and it'll be dinners and breakfasts and lunch on Saturday, and then um, basically it's going to be 48 hours of learning. I was joking with Tara that it is going to be where your sweats, your scrubs, your sneakers, your um, no Louis Vuittons, no Prada bags, no shopping for 3 weeks before you come. This literally is a true. Tara's like, what do I wear? I only wear heels.
I
um,
was
but
like, oh
what
no,
we
my
really, yeah, I mean, we really want this. I mean, there's so many great meetings out there, and so much learning, but we really want this to be a meeting that is going to focus on helping the learning injectors who have 3 years of experience or less really be able to talk to these legacy injectors, to learn from what they have learned through the years, to have them as mentors, to ask questions, to learn, kind of how did we get here. So Tara, I can't thank you so much. Tracy says, yeah, this is not a fashion show. Education is not entertainment. Yeah, I think that was the most posted picture from my presentation at IceFan was, when did we go from aesthetic medicine to aesthetic entertainment? And
And that's such a huge topic because, especially with Instagram, it's hard to validate proof. There's injectors that have 60, 70,000 followers, but are they worth their grain of salt? No. There's injectors that have 500 followers and they're brilliant. So where do you figure out what's what and who's who and somebody worthy? You mentioned something about you're having an upcoming topic, and I think it's so profound that you're having this. I read an article pre-COVID, and it stated that 2% of the world has body dysmorphia. In every single day in an aesthetic injector's practice, they see 15% of that 2%.
wow.
And that was pre-COVID. So I can only imagine with the onslaught of Zoom dysmorphia of, how the rate has grown. And I'm seeing a lot of it. And I think we've had some classic topics of body dysmorphia. We know exactly what that patient looks like, but I'm starting to notice, and I've added on the notion that if the patient is being a bully, I'm starting to categorize them in that body dysmorphic and I'm not treating them. So I'm excited for that topic.
That's been, and yes, Judy, I promise I'm going to have an email soon. I literally keep waiting for the email for, I mean, my newsletter for two things. One, I am still finishing the Insights Guide because for some reason I'm on major procrastination mode with that. And secondly, I need to get all the information on the website up for Learners and Legacy. So, Tara, thank you. Sorry, I was answering Judy's chat question there, and I didn't even finish acknowledging your amazing conversation about body dysmorphia. And I think those are things that, as we continue to enhance education opportunities for injectors across the country, having experienced injectors like many that are on the call tonight, be able to share what they have learned, not just in terms of injection technique, but in terms of treating patients is going to really make a big difference. So I'm going to go ahead and stop recording. Thanks you guys so much.